BCS classification for the drug molecules is based on the solubility and permeability characteristics. There are four classes: BCS class 1, 2, 3 and 4. BCS class 1 is with high solubility and high permeability. BCS class 2 is low solubility and high permeability. BCS class 3 is high solubility and low permeability, and BCS class 4 is with the low solubility and low permeability. Out of 4 BCS classes, the drug molecules belonging to BCS class 4 are most critical because these have the low solubility and low permeability. So I welcome all the viewers to this informative video on BCS class 4 drug molecules. Low solubility means the highest dose strength is not soluble in 250 ml or less of the aqueous media over the pH range of 1 to 7.5, or you can say that 1 to 6.8 pH. This is the BCS definition for solubility. And low permeability means the extent of absorption in the human is less than 85% by the oral route. That's why these are coming under the BCS class 4 with low solubility, low permeability. So these type of molecules are very challenging out of all the BCS classes. Challenges in the formulation: poor bioavailability, variable absorption, no bioair is there, difficult for the IVIVC, and the bio studies are required generally in the fasting and fed conditions. Poor bioavailability is due to poor solubility and poor permeability. Variable absorption may be because of some reasons we will see in the coming slides, and the variable absorption lead to inconsistent plasma drug levels. There is no bioair for these type of molecules. BCS class 4 drugs are not eligible for BCS bioair as per the regulatory guidelines ICH, EMA, US FDA. And it is very difficult to establish the proper IVIVC for these type of molecules, and IVIVC becomes impractical sometimes. Formulation strategies to get the better therapeutic effect, like enhancing the solubility, enhancing the permeability, and the other technologies which improve the solubility. Generally, the controlled release is not preferred because of the poor absorption, and formulations generally higher type of formulations are recommended. Solubility enhancement techniques like solid dispersion, nanoparticles, lipid based formulation, making the soft gelatin capsules, and pH modifications are done. For enhancing the permeability, use of some permeation enhancers, use of prodrugs, and sometimes transporter targeting is done. Examples may be more. I have included some of the examples like ritonavir, furosemide, and hydrochlorothiazide are the drug molecules belonging to BCS class 4. So why these drugs have low permeability and low or variable bioavailability? These drugs are low soluble, low permeable. So the reason first is poor aqueous solubility, and poor aqueous solubility will limit the dissolution in vivo. It limits dissolution in the GI fluids, which is a prerequisite for absorption, that result in the low drug concentration at the absorption site. Second is low and inconsistent intestinal permeability. So these are the drugs which poorly crosses the membranes, and because of high polarity, large molecular size or molecular weight, or lack of passive active transport mechanisms, there is low permeability. Efflux by the transporters like P-glycoprotein, these drugs may be pumped out of the absorbed site through the transporters. Then chemical or enzymatic degradation in the GI. Some molecules may get degraded because of the acidic pH enzymes in the GI before absorption, so it will reduce the bioavailability. Extensive first pass metabolism is the another reason which will degrade the API before reaching to the systemic circulation. Then variable GI conditions like gastric emptying time, pH, bile salts, and the food state like fasted or fed can further influence the bioavailability. Now see the regulatory considerations for the BCS class 4 molecules. Full BA/BE studies are required. There is no bioever permitted for the BCS class 4 drug molecules, and the formulations must be demonstrated with the discriminatory dissolution method. Also, IVIVC should be submitted. Sometimes IVIVC is not possible for this type of molecules, so full biostudies are required. Full bioequivalence studies are required to be done. Then there is a risk in the development of formulations with these molecules because these are having the complex nature in the biostudies. Some examples of the problem explanation and formulation strategy I have enlisted here. Low solubility, low permeability. So the problems are like efflux by the transporters, GI degradation, first pass metabolism, and variable GI environment. Low solubility can be solved with making the solid dispersions and cyclodextrins using the surfactants and nanocrystals and self-emulsifying drug delivery systems. Low permeability problem can be solved or can be reduced by the use of permeation enhancer by making the prodrugs and making the carrier mediated transport. Efflux by the transporters can be reduced by using the PGP inhibitors. Some formulation excipients can be used which can inhibit the efflux transporters, and encapsulation in the nanoparticles or liposome can be done. GI degradation can be prevented by using the pH specific or pH sensitive polymers. You can go with the enteric coating also, and enzyme inhibitors in the formulations can be used. First pass metabolism is difficult to uh, overcome, but if first pass metabolism is there, then other routes like sublingual delivery can be done, buccal delivery can be done, and making the products can be the answer. Variable GI environment like change in the pH affecting the drug absorption or fasted and fed state impact might be there, so it can be solved or reduced with the controlled release system. Sometimes you can use, then use the lipid based systems, and you can do some formulation modifications. So by these techniques you can solve some of the problems for the BCS class 4 molecules. Thank you for watching the video, and please do like, share and subscribe to this channel.